It's a great privilege to welcome Stephen Rauch to our Neurotology Grand Rounds. Steve is a professor of otolaryngology at the Harvard Medical School, and he's going to give us a talk on practical assessment of the dizzy patient. Thank you, Steve.
So great, thanks. It's really a pleasure to meet with you all and to share this. The talk this morning is very sort of clinical practical. I am not going to be talking about research and literature and citing a lot of science. So I hope this helps. I'm going to put my slide deck up in a minute here, but I just want to say that there's more than one way to tackle this kind of problem of assessing dizzy patients. And I am not going to talk at all this morning about the go, no-go decision of acute vertigo patient in the emergency room. You know, that question of whether somebody's having a stroke it's a life and death question, and there's great information about how to address that. David Newman-Toker from Johns Hopkins has written the definitive paper on that with a bedside group of assessments called a HINTS, H-I-N-T-S assessment. And if you've not seen it, I recommend you all read it in case you ever get called to the emergency room to see a dizzy patient. But that's not what I want to talk about. I want to talk about the people who come into the office with some kind of acute or chronic balance or vestibular symptoms. So this is my preferred title slide. This is the one that is requested by the chairman so that we get our branding on the screen. I have no disclosures. I do a little consulting for some pharma and biotech, but nothing that has any relevance to what we're talking about today. So the real challenge in assessing the dizzy patient is collecting the right information. And this is a cartoon about decision making. It's not specific to balance or dizziness. It's just a general cartoon about collecting information and making good decisions. And as you collect more information, your ability to make a good decision rises. However, there is a point where you've collected too much information and your decision-making ability goes south. You all certainly will recognize the difference between you or me, somebody with some experience walking into the clinic booth with the patient and coming out in 5 minutes with a pretty good idea what the problem is, or a third-year medical student going in and coming out an hour and 10 minutes later with 12 pages of notes and no clue what the problem is. And it has to do with finding this sweet spot where you collect the salient information and use that to guide your thinking about the problem. So I'm going to talk now about the salient information and how we apply it in thinking our way through an encounter with a dizzy patient. The only nod toward anatomy and physiology that I'm going to give you is this one block diagram of the vestibular system. And it's to remind you that sense of balance is different from all the other senses in that each of our other senses has only a single input. You see with your eyes, you smell with your nose, you taste with your tongue, but balance gets information from all over the place. 5 balance organs in each ear that read head movement, plus vision to tell you where you are, plus proprioception and other somatosensory inputs from the tips of your toes, up your legs, up your spine. And all of these inputs converge in the vestibular brainstem where they are compared and integrated in a very precise way that you learned as an infant and a toddler when you were learning to sit and crawl and walk. After that sensory integration task, the brain does another little bit of processing, and then it sends signals out. Some go out to your eye muscles so that your gaze will stay on target while your head is moving. You can drive on a bumpy road and still read the street signs. And some of those signals go down the spine so you can stand and walk and dance. And if there's a problem anywhere in this system, the sensory inputs, the central integration and processing, or the motor outputs, patient feels like their balance is messed up. And it's our job to help them move toward relief or improvement. So in collecting information, there are really two categories of information that I want to recommend to you. And again, just as an aside, I want to declare that this approach is not the only approach. There are plenty of other ways to tackle the dizzy problem. And David Newman-Toker, whom I alluded to earlier, takes a totally different approach in his teaching about how to think about dizzy patients. And so this is not the last word on dizziness, but this is an approach. And it's one I recommend because I find it simple and quick and effective. So the first parameter is the one listed here on this slide. What flavor of dizziness does the patient have? And we all learn early in our training that the word dizzy really is not informative, and we have to get rid of that word and get on to something else. Without putting words in the patient's mouth, we have to get them to describe what they feel. And so dizziness comes in 4 flavors. The first flavor is people who feel like they're going to pass out, or actually do. And any of you who've been down on the floor doing crunches or some other workout and are a little dehydrated and stand up too fast know that feeling of having a brownout, of near syncope. And this is a symptom of inadequate cerebral perfusion. And it might be from dehydration, might be orthostatic, but it might be from carotid stenosis or vertebrobasilar insufficiency or cardiac valvular disease or anemia, but it's cardiovascular and neurovascular. And people who feel like they're going to pass out really don't belong in my office. They need to see an internist or cardiologist for the next evaluation. The second flavor of dizziness is disequilibrium, and I'll define that for you as a feeling of impaired spatial orientation or imbalance. These are people who feel like they might fall, they feel insecure or unsteady, or lost in space. And I like to subdivide this into 2 types of disequilibrium. One of them is gait disequilibrium. And these are people, I ask them, when do you feel this? How do you feel sitting here in the chair? And they say, oh, I feel fine. And I say, what about when you're lying in bed? Nope, feel fine. What about when you're driving? Do you still drive? Sure, I drive, no problem. Well, when do you feel dizzy? And it turns out they only feel dizzy when they stand up and they're on their feet. And sometimes it's instantaneous as soon as they're up on their feet. Sometimes it comes on after they've been up for a little while. But the salient feature is that this only occurs when they're standing. And what I'm thinking about in somebody with gait disequilibrium is the lower half of their body. Are they not sending normal signals up? Are they not sending normal signals back down? Is there something in the middle? You know, is this a sensory neuropathy? Is it spinal stenosis? Is it some sort of cerebellar ataxia or movement disorder, Parkinson's or something like that? Or is there some descending long tract problem? Or is there truncal muscle weakness, polymyalgia rheumatica, or muscular dystrophy or something like that, post-polio syndrome? I'm worried about the control of the lower half of the body. So, I evaluate these patients, but I'm thinking we need to get you to the neurologist or the physiatrist or the orthopedist for some further assessment about the lower half of your body and its control. In contrast to that, the other subtype of disequilibrium I call global disequilibrium. And these are patients who feel lost in space a lot of the time, maybe all the time. They just feel like their head's not on right. They have this kind of jello-headed, swimmy, floaty, boaty, walking on marshmallows, walking on a trampoline, squishy feeling. And it may be aggravated by head movements or position change or gaze shifting, and I collect some of those details, but the key that I'm listening for is, do they have an impairment of spatial orientation, and is it only when they're standing, or is it also at other times? And these people certainly belong in my office, although there are many causes of disequilibrium that have nothing to do with the ear. But I'm happy to tackle those. The third flavor of dizziness is vertigo, and I will define that for you as an illusion of motion. Now, we all know and love rotatory, rotational vertigo, warms the cockles of my heart. But in fact, I consider it to be vertigo if there's any other illusory motion. If people feel that there's a force driving them to one side, if they feel like they're rocking or bobbing or swaying on the deck of a ship. Some people feel like the floor drops every once in a while. Maybe you've had that feeling if you're in an elevator and it suddenly makes a little shimmy or judder of a few inches. But all of those instances where the patient has the illusion that they are moving or the world is moving about them, that's vertigo. And they absolutely belong in my office. But once again, it's not necessarily ear disease. And the last flavor of dizziness I've listed on here as psychogenic. And by that I mean these are people where their dizziness is a pure psychiatric perceptual distortion. And when you ask them to describe this dizzy feeling, what they say is that they feel spacey, or they feel disconnected, or a little bit out of it. Some people I've heard say that they feel like they're watching the world on television, but they're not right there. They're sort of removed from the reality around them. If you've ever taken too much NyQuil, I think you know this feeling of just being a little out of it. And people use that they call it dizzy, but then when you press them on it, there is no impairment of balance, there is no illusion of motion. I could not begin to tell you how many patients I've seen over the years who come to see me because they're dizzy, and they've been dizzy for years, and they've seen many other doctors, and they've been taking TID meclizine for a decade, and they start talking about their problem, and I finally, scratch in my head, say, wait a minute. Does this affect your balance? And they say, oh, no, not at all. Nobody ever asked. All they did, the patient said they were dizzy, they got a prescription for meclizine, they've been on it for 25 years, they're still dizzy. So it really is critical that the first thing you do, the lowest branches on this decision tree, are this discernment of what does this patient mean when they say they're dizzy. The syncopal or near syncopal patients get a cardiac workup. The disequilibrium patients, if it's global, they're mine. If it's gait, they probably need a neurologist. If it's true vertigo, it's certainly mine. And if it's psychogenic, I listen to the problem. Being neurotic or anxious doesn't protect you from inner ear disease. You certainly need to listen to the story and not just let your mind slam shut that it's a psych patient. But you do need to have, you know, a psychologist or psychiatrist on speed dial that you can refer some of these patients to for further assessment. The second parameter in my dizzy assessment is displayed here, and I'm calling it the trajectory of the disease, or the trajectory of the symptoms. And by trajectory, I mean the path, the course of symptoms over time. And I have 3 cartoons on the slide with symptoms on the vertical axis. Normal is at the top, rotten is at the bottom. I'm not giving you any units. I'm just saying they're better at the top and they're worse at the bottom. And time is passing from left to right, and I'm not giving you any units of time. But I've displayed here 3 common inner ear disorders. And without giving you any other information, I would bet a lot of money that you know exactly the diagnosis for each of these 3 different patients, just based on a sketch, a cartoon of their symptom trajectory. I really want to impress on you the power of thinking about it this way. And you could even draw this in your notes or ask the patient, give them a piece of paper and a pencil and say, you know, sketch your symptom trajectory. The first cartoon, the one on the left, is obviously vestibular neuritis or labyrinthitis with a sudden onset and a sort of asymptotic recovery toward normal. The second cartoon shows a patient who has attacks where they're really bad and they recover, but over time they're not really recovering completely to normal. So there's a descending baseline punctuated by attacks, and that's a picture that you might see in a Meniere patient. And the last cartoon is somebody who has brief episodes of dizziness for a while, and then their symptoms clear. And that's what you might see in a BPPV patient. No units of symptoms, no units of time, but it is glaringly obvious what's wrong with each patient. So how do we use this approach? Figuring out the flavor of dizziness and looking at the trajectory of disease. So I start with this little diagnostic dizzy matrix, and these are for the patients who have acute vertigo. They really do have an illusion of motion, spinning, or profound balance impairment. They're hanging onto the walls and the furniture. And I've sneaked in one other parameter because we're all ear docs, and that's hearing loss. And again, I'm not giving you any units. I didn't ask if it's fluctuating or progressive or sudden or chronic. All I ask is hearing loss, yes or no. And years ago, I had a fellow from Finland, and she and I took this simple 2x2 block diagram table, and we made a 3-question questionnaire. You know, do you have vertigo? Yes, no. Is it in attacks or is it continuous? And do you have hearing loss? Yes or no? And we had every patient answer those 3 questions in the waiting room before they saw me. And then I did my full evaluation, and we eventually had a diagnosis on each patient. And what we found is that there's a pretty unique solution to the matrix, 4 diagnoses to fill in these 4 boxes. And that solution to the matrix is correct 60 to 80% of the time, just by answering those 3 questions. Hearing loss, yes or no. Vertigo, yes or no. Episodic, if it's yes, is it episodic or persistent? And I think you could fill in the matrix easily enough. Here's the answers. If somebody has vertigo episodes and hearing loss, 60 to 80% of those patients have Meniere's disease. If they have episodic vertigo and no hearing loss, they probably have BPPV. Now, you can certainly ask them, how long does a vertigo last? And if it's 20 seconds or if it's 2 hours, you know, you have an absolute discrimination between these 2 disorders. But you don't even need that. 80% of the time, you're going to be right, just filling in the matrix. You know, there are no ENTs out in your community or mine who make a correct dizzy diagnosis 60 or 80% of the time. If you do it like this in about a minute and a half, you're going to be like the local hero. And on the persistent side, persistent vertigo is going to be labyrinthitis or vestibular neuritis, and the difference is that everybody with labyrinthitis, by definition, loses hearing when they lose their balance. They've pickled their whole inner ear, and in vestibular neuritis, the cochlea is unaffected. So if you have people with acute vertigo problems, start here, and you will probably have the answer more than 50% of the time, just with this simple matrix. Now, unfortunately, not everybody fits in the matrix, because sometimes this doesn't give you the answer, but a lot of people don't have acute vertigo. They have disequilibrium, or they have some complicated combination of disequilibrium and vertigo. And so that leaves us with a handful of other very common neurotologic diagnoses. And so I'm going to spend the rest of my time walking through those with you. Here are the 4 conditions that you need to know. You know, they just have to be in your hip pocket all the time. One of them is progressive disequilibrium of aging. The next is vestibular migraine. The third is persistent postural perceptual dizziness, 3PD. Used to be called chronic subjective dizziness, and cervical dizziness or cervical vertigo. So I'm going to walk through each of these to remind you of the clinical presentation and how we think about them. So this one, PDA, progressive disequilibrium of aging, is this story that I expect you know well. I walk into the clinic booth, and there is an aged patient, 70, 80 years old, sometimes older, and 2 or 3 or 4 of their adult children. And the story is that mom or dad, over the last year or 2, has been getting more and more rickety on their feet. They have trouble getting in and out of the car. They have trouble stepping off the curb or going up the stairs, even maybe trouble getting out of their easy chair. They've fallen a couple of times. They might have, broken their glasses and gotten a black eye, ended up in the emergency room with a scalp laceration or a broken wrist. Often, the trigger event that gets them to my office is that a few months ago, there was some other medical intervention, iatrogenesis imperfecta. They had a hip replacement, or they had one of their 2 cataracts operated, or they told their primary care doctor they were dizzy and they got put on meclizine 3 times a day. And their gradual trajectory of decline went off the cliff because of one of these other changes in their sensory or motor function. As you probably well know, these patients have multi-system decline. Every aspect of their balance system is losing it. Just as they may have some age-related hearing loss, some presbycusis, their inner ear balance organs may not be sending as much information as they once did. We know that a significant proportion of the population just loses inner ear hair cells, vestibular hair cells with age, or has degeneration in Scarpa's ganglion with age. Their vision is not what it used to be. They may be wearing bifocals or trifocals or progressive lenses, which make it great when they want to read, but if they look down at the floor, they're looking at the floor through the reading part of their lenses, and it's blurry. And they may have cataracts or macular degeneration. They may have had their intraocular lenses that are optimized for something other than looking down at the floor. And so their vision is impaired. They may have all kinds of other sensory impairments. It's not unusual for this patient who's in my examining room to be wearing a pair of Reeboks that are 3 sizes too big because they have bunions and their feet hurt. So they're walking on squishy sponges all day and they don't feel the floor. And maybe their ankle proprioception is not so great, or they've got a little lower extremity neuropathy from B12 deficiency. They've had both hips replaced and one knee replaced so that they've got titanium instead of proprioceptive nerve endings. They may have spinal stenosis or disc disease so that the sensory information ascending from their legs is reduced. When these variously reduced sensory inputs get to the brain, it's an 86-year-old brain, and it doesn't process the way it used to. And they're on meclizine that makes them groggy. And they're on a benzo because they're anxious and it makes them groggy. And they're on a sleeping pill because they're not sleeping well and it makes them groggy. Somebody who has this reduced peripheral vestibular information needs every neuron firing. And their brain is wrapped in saran wrap by all these sedating drugs that have been piled on to treat their various symptoms. And then, when they do have efferent signals coming from the brain back out to the rest of their body, they're rickety, they're stiff, and they're weak. They've been sitting, they're more and more sedentary because of their fear of falling, so they're deconditioned, and they're ripe, primed to take a fall. The statistics on falling are really horrifying. After age 60, 50% of accidental death is a result of a fall. For patients over age 65 who fall and break a hip, 20% of them are dead within 1 year and 50% are dead within 2 years. Horrifying. People who fall get injured, and people who get injured from falling die. So these patients need a multi-sensory, multi-system tune-up. They need their vision fixed up. They need their hearing aids fixed up and hearing fixed up. They need podiatrists to take care of their feet. They need to work with a physical therapist on conditioning and gait training and falls risk management. They need their medication list debrided down to the absolute essentials with an effort to avoid anything that sedates them or makes them orthostatic. They probably need a safety inspection in the home by a visiting nurse or an OT to be sure they have non-slip surfaces and night lights and safety grab bars by the tub and toilet. If they have stairs, the handrail has to support their body weight. They need to get rid of extension cords and little area rugs, low pieces of furniture, because if they trip, they're going down. When I talk with the patient and their family about this in the clinic, they totally get it. I mean, they understand that nothing I recommend is going to make mom a star on the tennis court or the dance floor. That's just not a realistic expectation. The objective of treatment is to preserve this patient's safety and independence for as long as possible. They totally get it, and they go home with a mission of how to help improve this patient's quality of life. The second one of these chronic dizzy problems that I see a lot of is vestibular migraine. And I have to tell you, this has become a bigger and bigger and bigger part of my practice. I have really backed into being a migraine doctor. I have a huge migraine practice. When I went to med school and in my training, migraine is a neurological problem. It's a headache. But that's an old-fashioned way of thinking about migraine, and any of us who have a significant population of vestibular patients really have to learn how to assess and treat migraine. And they are some of my happiest and most successful treatment encounters. Migraine, as you all know, is a profound throbbing headache with nausea and vomiting and photophobia. That's the textbook description, and it's true. But it turns out that 25 to 30% of people who have a history of migraine headache or ocular migraine get dizziness and vertigo. It also turns out, and it's not part of this talk, that a lot of people with migraine get fluctuating hearing loss. And there are a bunch of us who think that otherwise idiopathic fluctuating hearing loss may be cochlear migraine. Now, you can think about that. I'm not going to spend time on it. But I actually have patients whose hearing fluctuates wildly, and when their hearing drops, they take Imitrex, a sumatriptan, their hearing pops back up. Wow. Modern understanding of migraine is not your bubby's migraine. It's not just this ice pick through the eyeball throbbing headache. If you let a migraineur tell their story of symptoms to you, what they tell you about, sure, they are sensitive to light and sound, but they are sensitive to tinnitus. Their tinnitus is screaming and intrusive. They are sensitive to motion, self-motion, and motion of the world about them. They cannot tolerate, and a lot of them for their whole life, they've been car sick. And in fact, if they have adult onset motion intolerance, that's pretty much diagnostic of migraine. Nothing else causes that. They're intolerant to visual stimulation, visual flow and flicker, grocery store aisles, big box stores, fluorescent lights, scrolling computer screens. This stuff drives them around the bend. They cannot tolerate it. And, you know, well, right now during the pandemic, maybe you don't see this very often, but really this is our modern world. Visual overstimulation, you know, 3 or 4 levels of vertical segregation, moving walkways, people moving, flashing lights, mirrors. This chaotic visual field is impossible for a patient with migraine. Migraineurs don't process other sensory inputs normally. Pain is intensified, numbness, tingling, dysesthesias. And you know, when you start listening to a migraine, it reminds one of the little kid's story, the fairy tale of the princess and the pea, if you remember that story. Migraine patients are on chronic sensory overload, and everything is intensified and distorted. It's too hot, it's too cold, it's too wet, it's too dry, their clothes are too tight, their clothes are too loose, the bed is too hard, the shoes are too soft. It's unbelievable listening to the litany of stuff that these patients can't handle. And they sound crazy. They sound absolutely bonkers. When I was training, and some of you who are listening to me today maybe will remember these patients. When I was a resident and would walk into the clinic with Hal Shuknick, you know, he would see one of these patients and he called this floating woman syndrome. You would walk into the booth and there's a young woman sitting there and I'd say, "How do you do? I'm Steve Rauch." And they would burst into tears. And they were nauseous and they felt like they were walking on marshmallows, and their husband was on their case because they were no fun anymore, and their boss was on their case because their work productivity had tanked, and the kids were on their case because they couldn't drive the carpool, and they had brain fog, and they were nauseous, and they'd had $1 million workup, and everything was normal, and it was written off as a neurotic chick problem. But now we know these patients have vestibular migraine. So 25 or 30% of migraineurs have dizziness and balance symptoms. Migraine is not just a headache, and I think this is the best definition that I've heard. Migraine, modern understanding of migraine is that it's a neurological issue, it's in the brain, but it's a global disturbance of sensory signal processing. Well, remember, balance depends upon integrating sensory signals from your ears and your eyes and your long tracts up and down the spine. So if you have a problem in the sensory brain that screws up the calibration of those sensory signals. They don't fit together anymore the way they're supposed to. And it appears that probably 75 to 80% of people with vestibular migraine, it's on the basis of a failure of sensory integration in their CNS. That's not the only reason. We do know that migraine also disturbs blood flow, and it disturbs cochlear and labyrinthine blood flow. And there's some research evidence for that a number of years ago, in animal models particularly. And so it may be that in maybe 20 or 25% of our people with VM, vestibular migraine, they really do have end organ damage from the repeated fluctuations in labyrinthine and cochlear blood flow. They get episodic vertigo, and they get fluctuating and progressive hearing loss. Does that sound familiar? They meet absolutely all the diagnostic criteria for Meniere's disease. But if you dig a little deeper and you find out that every time they have a Meniere attack, it transitions, as the vertigo is winding down, it transitions to a blinding, incapacitating headache, and they're laid up for the next 2 or 3 days. That's not plain vanilla Meniere's disease. If their Meniere attacks are accompanied by photophobia, or numbness and tingling, or brain fog and word finding problems, that's not plain vanilla Meniere's disease. So migraine is an extremely common cause of dizziness and vertigo. In fact, it's 10 to 15 times more common than Meniere's disease as a cause of episodic vertigo and dizziness. It's treatable. It's real. The biology is really interesting if you want to dig in and learn about it. We think about vestibular migraine in patients who have a past or current history of migraine, and I take a headache history in every dizzy patient because they don't necessarily volunteer it. I'll ask, do you have any other medical problems? And they say, nope. And I say, well, what about migraine? And they say, oh, yeah. Or they say, well, not anymore. If you've ever had migraine, you're a migraineur. That's your brain chemistry, and you own it, even if you're in remission. Migraine is often hereditary, so you want to know if anybody else in the family is a migraineur. You want to know if they had it when they were young. You want to know what their history of motion intolerance, because that's such a high prevalent symptom in migraineurs. And you want to know whether they have anxiety and panic attacks, because anxiety and panic seem to coexist with migraine. And in fact, if you go to an anxiety clinic in the psych department, and you go to the dizzy clinic in the ENT department, and you go to the balance clinic over in neurology, what you find is that the people who have panic attacks and the people who are dizzy and the people who have migraine at the headache center are all the same patients. The Venn diagram is so heavily overlapping. So you have to ask about those issues. We know that migraine is triggered by other internal medical body events and also by environmental triggers. So you want to know if the patient's symptoms of dizziness relate to hormonal variation, puberty, pregnancy, and menopause, monthly menstrual cycle. Are they sensitive to stress? Are they sensitive to seasonal allergy, to dietary triggers? Maybe sodium, but what about diet soft drinks? What about MSG? What about red wine and chocolate and cheese? What about nuts? What about dehydration? What about sleep deprivation and sleep apnea? All of these environmental and medical triggers are huge in migraine and much, much less likely in plain vanilla Meniere's disease. And then, of course, some of the patients come to see you and they already have a diagnosis of atypical Meniere's. Vertigo attacks for years and perfect hearing. Well, come on. If your inner ear is degenerating and you have Meniere's disease for 10 years, your hearing is rotten. So somebody who has no auditory aspect, they have migraine. And even if they do have an auditory aspect, they may still have migraine. You have to figure that out. The pattern of vestibular symptoms in these groups is quite variable. Some people have their headache in temporal association with the vertigo, and then it's easy to connect the dots. But some people have vertigo instead of headache. Some people have this floaty-boaty chronic disequilibrium, not such clear-cut episodic symptoms, but maybe the environmental triggers. Basilar artery migraine is a quite unusual variant. It's also called Bickerstaff migraine, and these are people who have episodic posterior fossa neurologic events with a visual field cut or a visual inversion where the whole world turns upside down for 20 minutes. And this is a posterior fossa vascular type migraine. The reason that they're rare, but the reason you want to know about it is an absolute contraindication to using triptan medications because of the risk of causing posterior fossa stroke. And then the last thing about vestibular migraine that I've added here is this thing about disturbed baseline vestibular function. And what I mean by that is that for every other dizzy diagnosis, I not only have a picture in my mind of the trajectory of the illness, but I have a picture of the trajectory of the recovery or the response to treatment. For example, if somebody has plain old BPPV and I do an epi, they get better. But if I do an epi and the patient vomits, they have migraine. Normal people don't vomit from a Dix Hall Pike. If I do an epi and they're better for 3 days and then they're back, and then they're better for 4 days and they're back, and then they're better for a few days and it's the other ear, and then they're back and it's both ears, and then it's the right ear, and then it's the left ear, that's not a few crystals in their posterior semicircular canal. Somebody who is treatment resistant and has migrating positional vertigo symptoms, that's not a simple mechanical canalolithiasis. They probably have migraine. And people, young, fit, healthy people who get vestibular neuritis and they don't get over it in a month or 2 or 3, there's something else going on that's undermining their recovery. And then my antennae go up that maybe they have migraine and I didn't notice. Persistent postural perceptual dizziness is a psychiatric disorder. And the complaint is patients who feel lost in space. They feel like they don't know where their balance is, like they're a little bit swaying, rocking on the deck of a ship. They may have that rocking boat illusion. It might be fore and aft. It might be side to side. They may feel like the ground is a little bit spongier when they step down, like going off stairs. They don't know quite when their foot is going to hit the ground. They're very intolerant of self-motion or movement of the world around them. They can't tolerate escalators. They often have trouble riding in a car, at least if they're the passenger. They have a history of anxiety and panic. The story here sounds a lot like some of our migraineurs, but they don't have migraine. And in many instances, this patient's problem began with a quote, quote, real vestibulopathy. They had BPPV or they had a little neuritis, but that cleared away and they never quite got over it. One of the little pearls, one of the little salient things to listen for in a story of a PPPD patient is that as soon as they sit down, particularly if the chair has a high back and a headrest, or as soon as they lie down, their spatial problem immediately clears away in seconds. They feel fine. When they get back up on their feet, in a very short span of time, the illusion of spatial orientation trouble comes back. So as soon as they have tactile, on their back, on their butt, on their, as soon as they have other feedback, tactile feedback that they're grounded, they feel fine. But as soon as they're just standing up, a human standing is an inverted pendulum. Your ankle at the bottom and you sway at the top. As soon as they're back in that pendulum state, all of a sudden they don't feel secure. We understand this problem to be an anxiety disorder, a somatoform anxiety disorder, and you can think of it as a hypervigilance syndrome. Imagine if you're, having a heat wave in LA, maybe you can't imagine this, but imagine that you're walking along the sidewalk and all of a sudden you find yourself on a patch of ice and you stop and you tense up, you crouch slightly, and you become a little insecure and uncertain about your movements. You lose the relaxed fluidity of your movements. Your arms don't swing the same, your legs don't glide the same, and you become a little bit tense and herky-jerky as you move. That's a 3PD patient all the time. They just have this low-level insecurity about where is my balance, and they lose the relaxed ease of movement. We treat these patients with SSRI, SNRI, anti-anxiety medication. The definitive research study that showed efficacy was done by Mike Ruckenstein and Jeff Staub when they were both at University of Pennsylvania. Mike is still there. Jeff is out at Leahy Clinic now. But they took 150 patients, 75 got placebo, 75 got Zoloft, sertraline. The patients who got placebo, over the next 4 months, about a third of them recovered, and in the active treatment group, 80% recovered. The recovery is slow. It takes 3 to 6 months. You have to start with a very low dose of drug and creep it up gradually in the first month, because drugs in this family are a little bit activating, and they can actually make the anxiety worse before it makes it better. A lot of us now, instead of using we'll often use sertraline, but sometimes we'll use venlafaxine, Effexor, or Wellbutrin. These are all off-label, full disclosure, but they work. Whether you want to take charge of treating the patient or whether you want to send them off to the psychologist or psychiatrist, that's up to you. Vestibular physical therapy sometimes will help these patients, but a lot of times they're too anxious and they actually can't handle the therapy unless the therapist takes it super slow and rebuilds their confidence in their own balance. But this is very treatable, takes several months. The last condition I want to mention is cervical dizziness or cervicogenic vertigo. The clinical story is something we worry about when the patient has a history of neck stuff. Acute or chronic, old whiplash or sports injuries, discopathy in the neck, spinal stenosis or degenerative disc disease, repetitive stress or ergonomic things, people who hunch over a keyboard all day or have their, or looking down at their phone keying all day, people who play the violin or the flute, young adult, a young mom who has a toddler on one hip and is cooking dinner and trying to talk on the telephone at the same time, may have their neck in some weird position. So there are people who are at risk by virtue of neck strain. And the symptoms are two things. One of them is that the patient has a subtle feeling that their balance is just a little bit off. Probably not as bad as a migraineur or a 3PD patient, but they notice they just feel, a little waxing and waning disequilibrium. And superimposed on that wavy baseline, they have occasional zingers where they make a head-on body movement and they get a sudden white knuckle moment where the whole world suddenly makes one loop or tilt or lurch. It doesn't linger like a BPPV attack for 20 or 30 seconds or a Meniere attack for 20 or 30 minutes. It's very brief. One of my patients calls them spin zaps. And it's triggered by head-on body movement, but not stereotyped like BPPV where the same movement always triggers. Sometimes they look left, sometimes they look up, sometimes they look somewhere else. A lot of times it doesn't happen at all. It's very inconsistent and variable. In occasional cases, if you examine their neck muscles pushing back and forth, you'll find some splinting or guarding or tenderness, and even once in a while you'll find a trigger point, you push on it, and they'll get dizzy and have a few beats in nystagmus. It's quite impressive. Now, if you didn't think of this problem and you did a Dix-Hallpike and you rotate their neck and hyperextend it, there's a pretty good chance you're going to make them dizzy with your Dix-Hallpike, but it's not BPPV. And so if you're not really paying attention of, the direction and duration of the eye movement and all that junk, you could easily mistake cervical dizziness for BPPV. When I see a patient like this, I send them to the physiatrist, physical medicine and rehabilitation, for some neck and spine eval and treatment. Or if they don't want to go that medical an approach, to a massage therapist who's going to noodle around and find all their knots and spasms and trigger points. Big success in treating these patients. So, let me summarize. When I see a dizzy patient, I want to know what flavor of dizziness. Pre-syncope gets a ticket to the cardiology office. Disequilibrium, I divide into gait disequilibrium that probably goes to the neurologist, or global disequilibrium that I evaluate. True vertigo patients are certainly mine for a workup. And the patients with this psychogenic dizziness, where it really is not a balance symptom, but they feel kind of spacey or out of it, they go off to the psychotherapist after I give them a once-over. I want to know the trajectory of symptoms. Is it episodic or persistent? Does it come and go? What's the timeline? Is it trending worse, trending better? If they have acute vertigo, I try to fit them in that matrix of acute or episodic versus persistent, with or without hearing loss. If they don't fit in the matrix, I worry about progressive disequilibrium of aging, about migraine, about 3PD, and about neck problems. If none of those considerations answers the question, gets us to an understanding of the patient, then my patients go on to see a neurologist.